Broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. I'm Geraldine Bliss with the Phelan-McDermid Syndrome Foundation, and I'm delighted to welcome you today to part of our PMS Pathways educational series. Today's topic is going to be adult issues and participating in research. So a few years ago, I think around 2012, we began to hear about some troubling changes that were occurring in adolescents and adults with Phelan-McDermid syndrome. Unfortunately, what was in the literature was vaguely described as psychomotor regression and really has not been well characterized in the literature since. But as our community of teenagers and adults with Phelan-McDermid syndrome has grown, we're hearing more and more about neuropsychiatric changes that occur starting in adolescence. So the Phelan-McDermid Syndrome Foundation has been really concerned about this, and we want to ensure that this is an area that research resources are devoted to. And so as part of that, we have held the Phelan-McPosium, or we've had groups talking about what's happening as their children are aging. We have funded the Developmental Synaptopathies Consortium adult study, and we have worked with Dr. Tazy Kohlenberg on her Stories project, and we have supported the development of a new neuropsychiatric consultation group because we feel that this is just such an important issue for our community. So anyway, we're delighted to have Dr. Tazy Kohlenberg and Dr. Kolevzon with us today. Most of you may know Tazy as a parent in our community and the mother of a young woman, a teenage daughter, who has complex developmental and neuropsychiatric illness and was not too long ago diagnosed with a SHANK3 mutation. But what you might not know about Tazy is that she's also a physician. She's a developmental behavior, a board-certified pediatrician, and she completed an internship and residency in pediatrics at Einstein, and then a fellowship in developmental and behavioral pediatrics at the University of Massachusetts Medical Center. We're also joined by Dr. Alex Kolevzon, whom many of you know from his participation in past webinars and at the Phelan-McDermid Syndrome Foundation conferences. He is a child and adolescent psychiatrist and professor of psychiatry and pediatrics at the Icahn School of Medicine at Mount Sinai. He has been the clinical director of the Seaver Autism Center since 2007 and the director of child and adolescent psychiatry for the Mount Sinai Health System since 2014. So without further ado, I am happy to introduce you to Dr. Tazy Kohlenberg.
Thank you. And I'm going to cover two areas this morning. One of them is the preliminary results from the story project itself, and then talk a little bit about the neuropsychiatric consultation group. So how does the screen look, Geraldine?
Terrific.
Okay. So as Geraldine said, this project began as we realized that what had accounted for the really severe difficulties that hit our daughter at 14 turned out to be related to her SHANK3 difference. And I have just a little difficulty here with an overlay. So we're going to have to wait a second and see if I can move that so I can see what I'm doing. Good. Okay. So as Geraldine mentioned, Phelan-McDermid is associated with a number of neuropsychiatric problems that onset typically in adolescence or later, including something that looks like bipolar disorder, something that looks like catatonia, and episodes of developmental regression that can occur across the lifespan. So not just the typical autistic regression in the toddler or early childhood years. The project started with my search for answers and reaching out to other parents. And as I had long conversations, I realized there were things to know and began this project, which the goal of which is to capture in real detail the history and the evolution of symptoms in people with Phelan-McDermid who experience the onset of severe emotional issues with or without regression, and to use that information to help detect patterns that will guide research and lead to what we're all waiting for, which is better treatment and even prevention of these episodes and the deterioration that some people experience. The outreach was through the Foundation Facebook community, and in the end, 34 caregivers, almost all mothers, but one sibling guardian, who had between them 36 children, shared their stories through long phone calls and then follow-up calls and emails. All of the interviews were done by me, and in addition to the developmental behavioral pediatrics training that Geraldine mentioned, I'm a trained child psychiatrist. And all participants whose stories are included in these data provided a release for that. So we face some challenges in defining terms when we talk about neuropsychiatric issues in people with Phelan-McDermid, because most of the standard tools that we have for defining and diagnosing psychiatric illness are hard to use and often not very keen tools for people who have communication disorders and intellectual disability and autism to start with. So for this study, we used descriptions of groups of symptoms that align well with the standard mental health diagnoses, but we did not make formal diagnoses based on the interviews. And I want to say really clearly that, you know, this study describes this group of people with Phelan-McDermid, this group whose caregivers chose to come forward to share their experiences. It does not tell us how common these experiences are in the general Phelan-McDermid population, and it does not tell us what will happen to any one person who has Phelan-McDermid. With that caveat said, here are some of the things we saw. People ranged in age from 13 to 50 at the time that the conversations happened, with an average of 25. And there were many more females than males in the study sample, which isn't true of Phelan-McDermid in general. There were also a higher proportion of people who have point mutations or very small deletions within SHANK3 than there are in the overall registry database. But still, more than half of the people who took part had large terminal deletions. As to what kind of psychiatric illness and when did it hit, most developed mental health problems around puberty. A few in their 20s or later. The average age of onset was 14 years. And for most, a sudden onset of marked sleep changes was the first sign of difficulty. When we looked at the type of problems people had, they seemed to have mood episodes, either manic types of things or depressive types of things, or a combination of those that more closely resembled bipolar illness than schizophrenia. Hallucinations or delusions did happen. Those are psychotic symptoms, but they usually occur during mood episodes and were not persistent in between the mood episodes. And the symptoms that suggested catatonia were common, and they were often not identified as catatonia or treated. So I'm just going to take a moment to talk about what catatonia is. It's not a disorder on its own. It's a syndrome that tends to happen in the context of psychiatric illness and sometimes in medical illness. It takes at least a couple of forms. The one that we know from the movies is a sort of stuporous, immobile, unresponsive one that where people's arms can be positioned, and when you let go, they stay there. But there's also an agitated, hyperactive, hypermotoric version that can be hard to tease out from manic symptoms. So about a third of this sample had episodes that were very suggestive of catatonia as described by their parent or caregiver. And among those, half of them were not given a diagnosis and did not receive treatment for catatonia, though in some it was recognized during later episodes. So next, to talk about regression. Just to start with, loss of skills and changes in alertness are common during psychiatric illnesses, particularly in people with intellectual disability. So for analysis in the study, the way we did it is that the skills and the alertness returned when the psychiatric symptoms got better. We didn't count it as regression. But if the loss of skills started when someone was not psychiatrically ill, or it lasted for a long time after a psychiatric episode, we did count it as regression. How common was it? Well, most had some episode of regression. A few had the early regressions in speech and relatedness and play that are considered pretty typical of autism, and those occurred in the toddler years or around age 4 to 5. But many of the people in this rather specific sample had regressions that started around the time of their psychiatric illness. And a very few had regression that didn't start until long after the onset of their psychiatric symptoms. Some had more than one regression. And one of the big questions, did people get better? About half of those who had regressions recovered substantially from their regressions, while half had lasting declines. What were the skills that we heard were lost in regression? Kind of across the board, language and communication and interest in communication, toileting. The majority of the sample were toilet trained and independent for everything except sometimes wiping, but many lost that and lost other self-care skills such as basic dressing or the ability to brush their teeth. People lost some of their hand use and fine motor skills. And one thing that came up in quite a few stories was this pattern of hands being held hyperflexed at the wrist or up in front of the chest during acute episodes. Many of us, certainly we have seen difficulties with orientation, like knowing where the trash can is, or ability to carry out familiar routines such as buckling one's own seatbelt or getting dressed, or the loss of basic academic skills that had been acquired. There were changes in balance and gait and descriptions of people becoming stuck in positions or stuck at boundaries as they moved across doorways or in and out of cars. And many reported severe worsening of constipation, as well as bouts of difficulty in letting pee out, acute urinary retention. I know for parents like me, one of the biggest questions is what treatments are going to help. People with Phelan-McDermid did not show a consistent pattern of better or worse response to any specific medication. I wish I could say that we knew what to use, but we didn't. Antipsychotic medications were often tried and sometimes helpful, but they also cause difficult side effects, and in general, people with Phelan-McDermid seem to do better with lower doses than we typically use. And we know that antipsychotic medications can cause or worsen catatonia, and that did seem to happen in some of our sample. Many were benefiting from mood stabilizers such as valproate or lamotrigine or other anticonvulsants, and the grand old mother drug lithium was helpful for many. In those who had catatonia, benzodiazepines were helpful. That would be Ativan or Klonopin. And interestingly, 11 had aspects of their illness that made doctors think about autoimmune or inflammatory triggers. And so 11 were treated with immunomodulatory agents, such as some antibiotics that are useful for inflammation in addition to killing bugs, and steroids and IV immunoglobulin. And of those 11, 8 described clear improvement. we're really still in the early stages of analyzing these data, and there's a lot of work left to do on it and more to come.
Casey, I'm sorry to interrupt. There's just a little bit of feedback occasionally when you're talking, and it might, if you turn down the volume on your own computer, that might help resolve some of the feedback.
Great. I'm also hearing a whooshing noise as of somebody breathing into a microphone, and it's not me. Is this better?
It is better.
Oh, good. Thanks for telling me. So I want to close by thanking the families who've taken part in the project. It absolutely was the product of their generosity and gifts of time while juggling all the crises we know about in the background. And to thank the foundation for its very substantial support, and to thank Alex Kolevzon and Audrey Thurm and Pilar Treyes for their work on this. We're finalizing the article for publication, and there will be more to come.
Thank you, Daisy. Do you want to talk about the NCG, or is Alex going to cover that?
I'm going to talk about the NCG. And so, can people see this?
That looks great.
Okay. NCG, another product of the process of the story project, because so many families were dealing with wonderful caring doctors who were frank that they'd never seen somebody with Phelan-McDermid before and really didn't know how to help. And Alex Kolevzon has done an amazing amount of fielding those phone calls, but it seemed like it would be a good thing to have a more specific resource. So, as I said earlier, we know that patients with Phelan-McDermid can develop a lot of different difficulties, and we know that they don't always react well to the standard medication interventions for those problems, and that they're likely to be the one or one of two people with Phelan-McDermid who any given neurologist or psychiatrist or pediatrician sees in their entire working life. So we pulled together a group of experts, and we used something called ECHO. And ECHO stands for Project Extension for Community Healthcare Outcomes, which I think was just the words they reached for to come up with that acronym. And it's a wonderful model for transferring knowledge and capacity from experts in academic centers to a wide variety of providers all over the place. And the core of the model is that local providers bring a specific person they're trying to help, a specific case, to a team of experts, and they meet in a virtual conference room by video conferencing to discuss the case management. The goal is that if you do that enough, the local providers are going to be more and more comfortable in managing. This is a complicated slide, and it is the ECHO model's version of how it works, showing the kind of intersection of different processes that lead to better care and confidence. And it works in terms of what they call hubs. You can see on the left, which is an academic teaching center, or in our case, not a specific site, but a group of experts. And then the spokes, which are the care provision sites, and you see the little images of people who are the patients. The ECHO project, the Neuropsychiatric Consultation Group, was funded and supported by the foundation. The training from this program is all free, but you have to get there and you have to free up the time. And the foundation sent Alex Kolevzon and myself and Pilar Treyes to a training to learn how to implement the project. And then we pulled together a consultation team of mostly neurologists and psychiatrists and met monthly by video conference to make sure we were on the same page and share our resources and develop treatment approaches. All of the time involved in that and in the consultations is provided without charge by the members of the team as part of their commitment to the affected community. But in terms of the consulting physician, the local doctor treating a specific patient, they may be able to bill the patient's insurance for the time involved in taking the consultation. This is a possibly hard to read slide, but it shows you that we have 2 members in Europe and the rest of us are on this side of the world. These are the names of the participants in the team, and it's a really wonderful group of people. You'll notice neurology, psychiatry, neuroimmunology, genetics, and this is the second group of people involved. Lee Wachtel is an expert in catatonia treatment, and it's been a remarkable group. In terms of what kinds of concerns are appropriate to bring to this consultation group, this is the list. You'll notice it does not include seizures, it does not include GI problems or urinary tract problems or lymphedema, all of which are major challenges for a lot of families. But we're focusing on ADHD, sleep disturbance, irritability and aggression, and I really should have written in self-injury as well. Mood cycling or bipolar disorder, catatonia, and regression. This is a sample of a treatment algorithm that we've developed, and this is one of 6 that we've worked out. So in nuts and bolts, how does the consultation work? If a family and their physician agree that a consultation could be helpful, then together they fill out the intake form, which provides background, genetics, developmental history, and helps focus the team on the consultation questions. The physician then has to send that intake form to Dr. Kolevzon, who schedules a time, and all identifying personal information is then removed from the intake and it's distributed to the whole consultation group. The consultations are physician to physician, so family isn't in the room. During the consultation, the physician gets lots of ideas from the team and will then go and try them out. And if there's follow-up needed, they can come back to the group. We meet on the first Monday of every month by video conference. Our future goals, well, first of all, we've generated some good new ideas and developed these preliminary treatment guidelines. We are hoping to incorporate some experience with the consultation in the training of young physicians in neurology and developmental peds and psychiatry who may be working with individuals with Phelan-McDermid in the future. And we'll collect data on the impact of these consultations on physician comfort and confidence, and eventually on actual patient outcomes. And that is that.
Great, Tazy. This is so helpful. Thank you so much for sharing the information about your Stories project and about the PMS-NCG. I know I have some questions, and I forgot to tell everybody in the audience that you're welcome to submit questions via either the question feature or the chat feature located in the control panel. So if you have any questions, we'll take them at the very end after Alex's presentation. Alex, you ready to go? I'm going to transfer over to you now.
Yes, thank you. Oh, hi everybody. It's good to be back. Let me first congratulate Tacy on her first webinar. I first met Tacy, I met almost 2 years ago, and she would frequently begin with a disclaimer that she's not an academic, right? But I think we can sort of solidly welcome her to the academic community. The work that she's doing on this story project is Herculean. She sort of thanked a few of us. We've spent a couple of hours on it. Tacy's probably spent, I don't know, hundreds and hundreds of hours. So it's a remarkable project, and I think it's going to be a really important contribution. And then you heard about the consultation group, which I think is something we're all really, really excited about. I think it's going to be a very important way to kind of leverage our expertise and get kids access to better treatments. And I think it's forcing us to really think carefully through some of the challenges we face in terms of treatment. And you know, as I'm sure you're all formulating questions, I mean, a lot of questions come up as you hear about these issues of regression and these neuropsychiatric presentations, especially as it relates to adults. And so really, you know, for us, we don't have a lot of answers, and I know that's very frustrating for the community. It's also very frustrating for us. And so this very last part of the webinar is really focused on the importance of research in trying to answer and address some of these questions. So we were very grateful to the Phelan-McDermid Syndrome Foundation to fund an adult study, which is kind of a continuation of the child natural history study, where we're following kids over several different years, looking at all kinds of different medical and cognitive outcomes. And we've now extended that study with the support of the foundation to adulthood. So I wanted to talk just briefly about the study overview, some of the eligibility criteria, some of the procedures, so you get a sense of what this looks like. We have an enrollment goal of 30, and we're a little less than halfway there, and would very, very much like to finish this by, I would say, May, certainly by the end of this calendar year. Maybe Geraldine has some comments about the finances of it all, but it was sort of funded on a shoestring, but we do need to spend this time and this money to finish up the original goals. And we're hoping that this call, where I see 70 people on it, we only need, I think, 15 or 16 of you to come participate, so we would really appreciate it. And I'll talk a little bit about the sites so you have a sense of where you might be going in terms of what's most convenient for you. So we do have 6 sites: Boston Children's, one at Mount Sinai, Audrey Thurman at NIH, Rush, Stanford, and UT Southwestern. We were pretty careful with the foundation to select sites all across the country to make it as convenient as possible for families. As I said, we have an enrollment goal of 30. We've reached 12 to date. We'd like to finish the study by May. Our primary goals are to comprehensively characterize adults with Phelan-McDermid syndrome using a battery of medical, cognitive, and behavioral measures. We're also going to be collecting genetic information and genetic samples from patients and siblings and parents to try to determine whether or not there are other genetic factors across the genome that may contribute to some of the different types of presentations that you heard about from Tazy. So in order to participate, really patients just need to be 22 years of age and older at the time of enrollment. And this again is meant to complement the child study that goes up to 21. Participants have to be diagnosed with a mutation or a deletion that we know causes a loss of function of the SHANK3 gene. That's what we mean when we say pathogenic. And participants or the caregiver, as applicable, have to be proficient in English, because our assessments are mainly in English. And of course, the participant or the guardian, as applicable, has to be able to provide consent. For parents and siblings, we're going to be collecting genetic material and doing a very brief medical history form. And so the biological first-degree relative will be asked to participate. It's not a requirement by any means. So if siblings are available, great. If not, that's okay still. The participants that are the siblings or parents have to obviously be able to provide consent on their behalf or have a guardian, and they have to also be proficient in English as well. So I thought, oh wait, did I miss a slide? Subjects, oh, I did that right, okay. So this is an overview. I'm not going to go through all of these, but it gives you a sense of how in-depth the evaluation procedures are. We're going to be doing a lot of different evaluations. We're going to be collecting information from medical records, and in cases where we haven't done things like electrocardiograms or echocardiograms, heart exams or kidney exams. In cases when that hasn't been done, we're going to be doing them hopefully at the individual sites. We'll be doing cognitive testing, language testing. We're going to do some diagnostic testing specifically around the diagnosis of autism. We know that the SHANK3 gene causes autism in a significant proportion of individuals. We're looking at things like regression, adaptive behavior, repetitive behavior, sensory sensitivities, developmental coordination, aberrant behaviors, other kinds of presentations like hyperactivity or motor stereotypies that you heard from Tazy to an extent. For the adults in particular, we're very interested in quality of life. We're interested in this issue of regression and whether or not there are cognitive changes over time. So we're going to be using a screen for dementia. We want to know how people are functioning in general, so we're using an activities of daily living form. And finally, we've included now a sleep habits questionnaire. This is a children's sleep habits questionnaire, but it's going to be relevant for these kids because of the intellectual disabilities. And obviously, we know sleep is a very, very important area. We have a sense of how prevalent it is. We don't have a great sense of what the nature of the sleep problems are across the population. I should say that all of these measures were selected with sort of careful attention paid to relevance for the Phelan-McDermid syndrome community. None of these measures have really specifically been validated in Phelan-McDermid syndrome, but we think based on the questions and based on feedback to date that they'll feel at least relevant to the adults that you all are taking care of. And in terms of the time, so again, these are lengthy assessments. Overall, this should take about an hour and a half of caregiver questionnaires alone. So that's a lot of time I know that we're asking of parents. The parent interview sections are even longer, over 2 hours. And the testing that goes on directly with the adult is about 2.5 hours. So we usually do these over about 2 days with an overnight in between, staying at the center, or you can split it up and come twice for sure. Sometimes it can be over 3 days if it's too burdensome, depending on convenience. So we really want to make sure that we get a comprehensive look at the adults, and we also want to make sure that we do it in a way that can kind of extract the best performance. We don't want to, overly fatigue people. I should say that a lot of these measures, and I'm not sure if you can see this, can also be done remotely. So we recognize that many families can't travel with their adult folks with Phelan-McDermid syndrome for whatever reason. So I think in some cases we would be very open to doing assessments by the phone to the extent that it's possible, but it's not absolutely required that you travel for this particular study. So just to give you a sense of some of the sites, this is the Mount Sinai site. I work with Emma. Please call her if you're anywhere near New York. The Boston Children's site is also wonderful. Mustafa is running that site along with Sid, and please call Aaron. Audrey is our superstar at the NIH in Maryland, obviously, and she's got a wonderful facility, and I know people have really had a fantastic experience going there, and look how beautiful it is. So the NIH has some really great resources and fantastic expertise. It's definitely worth calling them if you're local. In Chicago, we've got the RUSH program with Elizabeth Barry-Crevice and Lata Soria. Please call Madison if you're interested in participating there. And over on the West Coast at Stanford, we've got John Bernstein, and you should please call Elijah with anybody that's on the West Coast. Or of course, there's also the Texas site at UT Southwestern with Cassandra, and please call it Adrian. And we'll make sure that we distribute these slides and certainly the contact information of all these sites. But we would really appreciate your participation, and we definitely hope to hear from you. So I thought now I could take some questions about the whole presentation, including from Tacey, and I'll kind of kick it over to Tacey for things that are specific to her program. And I don't know, how do you want to do it, Geraldine? I guess they're going to type it in.
We've got a few questions, and I'll read them out to you. And I want to start with one question, Alex. Could you help our community understand sort of the distinction between kind of the type of research that's emerging from the Stories Project and what is happening in the developmental synaptopathies consortium? Obviously, you went through, you sort of briefly, you showed the list of assessments that are done through the DSC. It's very, very comprehensive. But help us understand kind of more generally, what's the distinction sort of between this patient-centered outcomes research Stories Project versus the DSC natural history type of approach?
That's a great question. So I think that the work that Tacey's done has been very descriptive, and it's been mainly retrospective. So she's doing these extensive interviews with families. She's got some structure, so it is a semi-structured interview that she's using, but it's mostly based on kind of looking back, and none of it is a direct assessment. So other than perhaps being able to go through medical records, obviously Tacey as an individual and the Story Project in general hasn't had the opportunity to directly evaluate kids. So we don't have a good sense of, through standardized measures, exactly what their level of functioning is, either before or after the regression. The other big difference, of course, is that Tacey specifically elicited a group of patients who experienced regressions. I mean, there was a very strong, what we would call a selection bias. it's still extremely valuable because we want to know exactly what the nature and sort of duration of these regressions are. But what we're doing in the natural history study is more prospective, meaning we are doing a snapshot of the adult in this case at a given time. And the goal really is to capture a cohort of adults that we can follow over time. So yes, we'll be asking questions about the past. We'll be taking detailed information about the history, but we're going to be doing standardized direct assessments live in the moment, and then also hopefully following kids, or in this case adults, over time. And one of the questions we want to answer actually is, what's the prevalence of regression? What are the characteristics perhaps at baseline that might predict regression over time? What kind of kids might be vulnerable? And sort of what the differences are across affected folks.
I have a question for Tazy. Do you feel, you had mentioned that the majority of your participants were toilet trained and many of them lost continence for a period of time. So it struck me as sort of unusual. I think that in our community, there's not such a high prevalence of people that are toilet trained as in your study. Does that reflect anything about sort of the people who were the participants in your study, or how we identify people who are maybe beginning to have onset of neuropsychiatric issues? Do you know where I'm going?
Yeah, it's a great question, and I will tell you what I think, but I can't say that we know. I think this is a sample of people that is skewed towards folks who were more capable at baseline than is typical for people with Phelan-McDermid. So more than 3/4 were toilet trained, more than 3/4 had at least some speech of anywhere from short phrases to sentences. Quite a few had developed the ability to read sight words, and there were a few who were independent in the community or could safely be left home alone for short times before they got sick. So I think, you know, whether that's who one can more easily detect emotional illness in, or whether it's who is more vulnerable to emotional illness, or it's who one can more readily see regression in. I think these are all possible answers. There was a really strong sense of that sort of kid in this sample. And I know, you know, there were a number of conversations where people said, "Oh, sounds so much like my kid." Is that enough of an answer?
I actually think that that's, you know, this is a prime research opportunity to sort of merge the type of stories project you're doing with the type of assessments that are being done in the DSC. So we can sort of maybe look for factors that may, you know, oh, are we seeing certain genotypes that are more associated with onset of neuropsychiatric issues, or are we seeing that in individuals who have certain performance on various assessments or whatever, so we can begin to make those correlations, because right now I hear you saying we just don't know, right?
One point, which is I mentioned in the overview, is that there are a higher number of people with tiny, you know, micro deletions in SHANK3, of 1 base pair, 2 base pair deletions or substitutions. There's a higher proportion of people with that form of genetic difference in this population.
Okay, so we've gotten a few questions from the audience. The first is, will we be able to get these slides to share with our GP, our general practitioner? And I think this question came during your talk, Tazy. Are you willing to share your slides? I'm not sure. Is it going to be meaningful to physicians to view your slides?
I would say we should share the PMS-NCG slides by all means. I think that sort of describes some of the issues that we face and the challenges, and I think it invites the physicians to join the consultation groups. You know, obviously Casey's going to publish studies. I think until that is complete, it may be a little bit preliminary to share those slides.
Yeah, thank you, Alex. I think the other thing is that, you know, we're deep in the thicket of analysis, and I would rather share what we get to at the end when we publish than this preliminary cut.
Right, and the foundation will be happy to help disseminate a link to your paper when it's available. So, yeah. Okay, so next question, how many adults adult patients were involved in the study? And that was one of the first questions, so I think it refers to, Tazy, Your Stories project.
The range is 13 to 50, and I don't have the exact numbers on hand, but say at least 2/3 were 18 and older, ranging up to 50.
And what was the total number of patients that you had in your study?
36.
Okay, thank you. Notice the ECHO panel of specialists consists of physicians for children. Is there a reach for when the child becomes an adult? Our daughter has a hard time looking for specialists in her adult life. Seems no one is interested except for her neuropsychiatrist.
So we chose mainly child folks because child folks have adult training and feel comfortable treating adults, and because our adults developmentally are very much like children. And so we would feel 100% comfortable consulting to adult psychiatrists, adult neurologists, to whomever. But I think, I have a lot of confidence in this group in terms of being able to sort of think across the lifespan.
But the flip side of that, I mean, I think it's not obvious to many people that all of us who are child neurologists or child psychiatrists have adult training before we do child training. But the flip side, where do I find someone who wants to take care of my adult child with this disorder, isn't answered by that. And it's really one of the cliffs people fall off as they get into adulthood.
Yeah, that's a really, really tough issue for families. Like, where do they go? What do you recommend as a first step when a parent begins to recognize that something is changing in their teen or in their adult? What is their first step?
Alex, do you want to take that?
Sure. So I think that it depends, of course, on whether they've got a provider that's already engaged. But I get asked this all the time at the conferences, right? I think that you need to reach out to a physician, probably a child-trained physician, because they have more comfort with developmental disabilities, and you need to start to express your concerns. Because one of the things that we're hoping is that if you intervene early, you're perhaps going to either attenuate the course or at least increase the likelihood that the kids will recover after the regression or after the neuropsychiatric disturbance. So neurology, developmental behavioral pediatrics, child psychiatry, I think those three fields probably have the most comfort with developmental disabilities. Even clinical genetics in some cases, but those are hard folks to find sometimes. We have a major problem in child psychiatry, but we can't even serve the number of kids with mental health issues. We're a grossly underserved specialty, I think. But hopefully, combined with pediatric neurology, child psychiatry, development, all these fields together, we'll hopefully have enough capacity. But you go to your local area and you figure out maybe academic medical centers are places where you're going to have a better chance of finding someone that feels comfortable.
I think it's really hard for people who are not in these kind of meccas of medical care. Even in a medical mecca, it can be hard to find someone. And certainly part of the hope with the neuropsychiatric consultation group is that you'll be able to go to a psychiatrist and say, before you put my kid on large doses of X, Y, or Z, would you be interested in making contact with this? If I had one piece of guidance, and Alex, please chime in if you disagree, it would be start low, go slow, because I think our kids do tend to have more dramatic reactions as the doses get pushed up. Do you agree?
100%. 100%. It's never wrong to start very low, right?
Yeah, I think it's a great recommendation, to work with a psychiatrist who, try to convince your psychiatrist to refer to the NCG. It seems that, what we're hearing through social media is often a story of, families really struggling to get answers and having difficulty and working with their children's providers who are not experts in PMS. And so I'm hoping that many of the people out there in the community working with teens and adults with PMS will be excited about the NCG as a way to help build their own knowledge and ability to care for their patients with PMS.
Yeah, that's our hope also. I can say just this morning we got our first official consultation. It's the 7th or 8th case that we've discussed as a group, but this is the first from a physician outside our small community. They came all the way from Greece.
Wow.
So the potential reach is quite wide. And anybody that emails me or calls me now with questions, I'm trying to kind of funnel them toward the PMS-NCG. You know, it shouldn't just be me kind of weighing in on it. It should be this whole group. I think that's where we learn the most from it.
Right. Yeah. Okay, so we have a bunch more questions. Here's one. Have you seen loss of menstruation associated with the severe mood swings for two to 3 or more months?
I've heard about that. We know that stress can really mess up women's cycles in any condition. There's also this pattern of dramatic weight loss that a number of families report, even in people who appear to be continuing to eat normally, as if the metabolism has kicked up dramatically. So it's certainly a period of weight loss would be associated with change in hormone status.
One question came in, what were the selection criteria for the participants in Tazy's study? Was it patients with problems, right? Families are sort of self-identified, correct? Phelan-McDermid syndrome patients with these problems, or just PMS patients? I would like to understand how likely it is that that our son will have similar problems in the future. Thanks.
So the criteria were that they had to have something you would call a neuropsychiatric episode. So pure regression didn't count. And I had some wonderful phone calls with people who I learned a lot from, but their children really had not had a psychiatric component. And for the purposes of this study, there had to be some form of emotional illness. And boy, do we all wish we knew the answer to the question, how likely is this to happen? This study won't tell us. It's not that sort of data.
Right. So really what we need is like the DSC adult study to grow, right? We need a lot more. I mean, unfortunately, we can only fund a very small study, so we are only including 30 patients. But in the study that Alex was talking about, if we could scale that up to a larger group, we may begin to have a better idea of which patients are more likely to develop neuropsychiatric issues later.
One other confusing, confounding variable is that a lot of times with people who are older, the testing that identifies Phelan-McDermid is only done because something unusual like psychiatric illness or a drastic regression has occurred. These tend to be people who had whatever genetic eval they had, 15, 20, 30 years ago. And a small SHANK3 variant was not detectable then. So it's it's a skew of who gets tested and identified later in life.
I was going to add also that the only reliable way to try to assess the prevalence of things like regression is to do natural history studies where you follow kids over time. And that was exactly what we did, what we set out to do with the DSC. And the group of kids was 3 to 21. So we realized that's a good start, but really it needs to extend out into adulthood. In fact, when we submitted now back in the fall, hopefully the renewal to the DSC, we included adults up until I think 45, and we included even younger children below the age of 3. And so we're really, very kind of careful to be as inclusive as we can. And actually, we're going to, I think, hear in the next week or so about the scores for that resubmission. So we're really hoping that we can continue this work.
Exciting. So that's actually a perfect lead into the next question. If you do not get 30 participants under the desired criteria, would you consider a younger child, Alex?
So I think that depends a lot on the sites. So different sites have more or less capacity to do assessments that are essentially at this point unfunded. And I think that depending on where you live, contact your local site and figure it out. And hopefully they'll be willing to see you. I know that we're willing to see people no matter what under different protocols. We have a bunch of different protocols that are both funded and unfunded at this point, but we're open to seeing all families. One of the things that was really wonderful about the DSC, partly through the support of the PMS Foundation, was that we had travel support. So that we don't have for kind of related protocols. But I think if you have a child that's younger than 21 and you want to have them assessed by one of these sites, we will find a way to make that happen.
So that was one of the other questions that came in. Is there travel support for the adult study?
So no, the travel support is, well, so the support in general is very limited. This was sort of a symbolic effort to show the importance of collecting data from adults and for kind of moving in this direction. And we're going to be hopefully using these data to support much larger grants that will eventually have travel support. But for the moment, we don't have travel support, unfortunately.
Right. So the Phelan-McDermid Syndrome Foundation provided travel support for the developmental synaptopathies consortium with the younger individuals up to age 22. But for the adult study, we did not have sufficient funds to provide travel grants for the adult patients. And we hope that, in the future, that may be something that we can revisit, assuming that the developmental synaptopathies consortium is refunded by the NIH. So, in our experience, neuropsych issues are brought on by tolerating issues. How does the ECHO project team work through treating neuropsych issues when GI, urinary tract issues, or even kidney issues could be a core cause of the neuropsychiatric complications, or does the protocol not work in this example?
So actually, we put a lot of thought into making sure that we weren't jumping to kind of neuropsychiatric treatments before making sure that a whole host of medical problems were first ruled out and worked up. So yeah, for us, believe me, this group is very sensitive to the idea that gastrointestinal problems cause psychiatric problems, that seizures cause psychiatric problems. So if you look closely at the algorithms that we've developed, the first chunk of it is actually first, let's rule out all these other issues. So we're sensitive to that. I think there was a great webinar, I guess it was last week or 2 weeks ago, specifically on GI issues. Our hope is actually to start to form other consultation groups, but they wouldn't be neuropsychiatric. They'd be, a GSG, right? A gastrointestinal consultation group and an epilepsy consultation group. I think that none of us as pediatric psychiatrists and psychologists and neurologists feel comfortable making recommendations around bowel management, but I think that we're very careful to make sure that patients are worked up appropriately if those seem to be important issues.
We have a couple of questions from folks in Canada. They would like to know, can people in Canada participate in the study and or access the ECHO program?
Yes and yes, absolutely. But we don't observe any geographic borders.
And just to mention, the Story Project includes people from Australia, New Zealand, 2 countries in Europe. This disorder doesn't know boundaries, and the commitment of the people working on it doesn't know boundaries.
So the other question from Canada is really what is the best site to get involved with? And I would say, maybe Boston Children's for people in Eastern Canada. If you're in the Western area, Stanford may be the other site that you would consider, or possibly Rush Memorial in Chicago. Let's see. Tazy mentioned in an earlier slide that 8 of 11 patients were treated with, she wrote, autoimmune blank, blank, blank. I missed some of that info. Can she tell us more?
This is a hot and contentious topic, and so I want to be very careful in how I talk about it. There's a lot of interest in psychiatry and neurology now on the role of inflammation and immune and autoimmune, which are not the same, processes in the triggering of a whole range of disorders, including the dementias and ALS, and bipolar and schizophrenia. We're really looking at this now. There's also this whole group of autoimmune encephalopathies. The book and movie Brain on Fire are about one of the most dramatic cases of that. And there's this question called PANDAS or PANS, which is clearly a thing, but how big a thing and how many different things it really covers is becoming challenging. And so what we noted was that a number of people, including our own daughter, had such acute onset with such interesting neurologic components that it was treated as if it might be an immune or inflammatory disorder. And I don't have enough medical data to be able to say anything with confidence about whether this group of patients were alike each other in ways that were different from the other people in the study, but they did respond. More than half responded to some degree to this treatment.
Thank you.
I'll just say one more thing, which is that the management of autoimmune disorders often uses steroids, and steroids can make mania go completely ballistic. And so that's something that people with our kids need to keep in mind.
Alex, I think this is a question for you. Does the individual have to have had regressed? My daughter is high functioning, however, she does not talk and she is not toilet trained. Could she still participate?
Yeah, of course, absolutely. Yeah, 100%.
There was another question also related to participation. What about individuals who are lower functioning was the question.
Again, we're really interested in seeing all kids and adults, and the whole point is to try to capture as broad a population as we possibly can, so we really understand what the variability is.
Perfect. What about children who are currently part of the natural history study, the child study? Will they be included in the adult study once they reach the appropriate age?
So there's 3 time points. There's the baseline, there's year 1, and then there's year 2. So if they enrolled at, let's say, 20, they would continue to be followed into their early 20s for sure. The goal of the continuation or the resubmission of the DSC is actually to continue following them out for additional time points. So yeah, we would like to continue following them, and if we get funded, we will.
So in other words, if the NIH refunds the Developmental Synaptopathies Consortium, then kids who are currently enrolled will just be able to continue up through age 45 or whenever the grant funding runs out.
Right. So I think what we had proposed was for people who had participated in the original DSC, and they had basically time points where they were evaluated at baseline 1 year out and then 2 years out of baseline, we would actually try to follow them up at 4 years and 5 years out. I have to double check that, but I think that's essentially what we were thinking. So they wouldn't be 45, right? Because that would be potentially, 24 years out. So it'd be great if we're still being funded in 24 years, and if we are, then we will continue to see them, yeah, by all means.
Right, okay.
And following the kid cohort through adolescence might be one of the really good ways to answer the question, how common is psychiatric illness? Because we have that group of kids and we can look at them as they get to 20 and see what's going on.
And also that ability to look at all that other data and maybe try to find factors that might be predictive or help us understand who is susceptible to developing other issues later in life. We have a question here that's, I think, an important one. What does catatonia look like? And this is, the question is actually, what does catatonia look like related to agitation? But what does catatonia look like to families? What should they be looking for? I mean, from the, most families don't know that much about it. They just know that some things are happening to their child. So what should they be looking for?
Alex, you go first, and then I'll talk.
I'll do sort of one half of it, and then you can do the other half. I think we probably have complementary experiences here. So if you watch movies, like Tacy had mentioned, the kind of classic sign of catatonia is when you put somebody's hand in a certain position, and then they'll leave it there even after you move your hand. That they essentially are frozen to some extent. So the kids that were, I haven't seen a lot of these cases in Phelan-McDermid syndrome, but adolescents who were verbal stop speaking. Adolescents who are completely ambulatory stop moving. If you ask somebody to stand up out of their chair, they may follow that direction, but then they won't start to walk unless you prompt them. If you hold up their arm and then you let go of their arm will stay in that position. So those are sort of the classic features. That's how it's most described in the literature. That's how it's most portrayed in film. I think, as Tacey kind of alluded to, there's some controversy because the definition is now spread out, and there are many, many different types of manifestations of catatonia. We actually enlisted the support of Lee Wachtel, who's like an international catatonia expert, not just in the diagnosis of catatonia in the context of autism and developmental disabilities, but also in the treatment of catatonia. Because even though it sounds very scary, actually one of the really important things is if you are able to identify it correctly, you can treat it pretty effectively, which is remarkable. And often what ends up happening in the community is that medicines that are being used to treat what people think are or what they think are neuropsychiatric presentations are actually either inducing or making catatonia worse. The more kind of complex picture is the sort of agitated catatonia. Maybe you can try that one, Tazy.
So I just want to mention, and I would imagine that the majority of people listening to this call have the opportunity to be part of the Facebook community. And because desperate parents, including me, will be more free to share things, you can actually see videos of some of our children during catatonic states. So what we lived with our child and saw, we've had now 4 bouts, and 3 of them were recognized. The first one, nobody, including me, recognized, was the onset of radically different behaviors. It's really important to note that these don't count if they're baseline. But for the first time in her life, she started repeating words over and over and over and over. So you can see repeating both of what someone's heard or of their own phrases. It's not communicative. It's almost tick-like. It's very driven. You can see really restless, driven physical behavior. Blood pressure changes, skin perfusion changes. So a number of us have seen these big bright red blotches come and go usually on the upper torso, face, and neck. It can include a sort of endless stream of language. And again, these things are not typical for a person when they're well. And they can run fevers. They can stop eating. They can have urinary incontinence. There's a lot of drooling, typically in some of the patients. Much more to say about that, but those are some of the things that can be manifestations of catatonia.
Thank you. You know, we've gotten a few more questions. Unfortunately, we've run out of time to answer them. But I will just say, just to sort of reflect on some of these remaining comments and questions, there's definitely a sense of that it's difficult for people to find providers who are interested and knowledgeable about the kinds of problems that teens and adults with Phelan-McDermid syndrome are experiencing. And then there are also several people have just expressed their thanks that you guys are working on this issue and that there's finally some research attention coming along. So thank you guys for spending an hour with us today and telling us about the research efforts that are currently, that are ongoing. And we're hopeful that your efforts will lead to some recommendations that can really make substantial differences for individuals who are kind of undergoing these very, very difficult changes. So, thank you.
Thanks.
Goodbye, everybody.
Bye.